Hi, my name is Colin Feeney, and I'm the director of the Medical Intensive Care Unit here at Highland Hospital in Oakland. And today I'm going to talk about recruitment maneuvers. So these are used in ARDS, and ARDS is alveolar flooding, a loss of surfactant, and alveolar collapse. So this is why PEEP is so helpful in ARDS, because it can open up those alveoli and improve gas exchange. Sometimes, even though you're on PEEP, you're still having problems with oxygenation. So in some patients, the application of much higher pressures for short periods of time can improve oxygenation. There's a lot of ways to do recruitment maneuvers. You can use sustained positive pressure, or CPAP. You can do stepwise increments in PEEP, or you can use pressure control ventilation. Does this really help patients? Well, there's conflicting evidence. It definitely temporarily improves oxygenation in many patients, but there's not a lot of data about improving survival. But again, this is true for a lot of things about ARDS, and often we're just trying to buy some time to allow the lungs to heal while we're using lung protective strategies for the patient to get better. High pressures can cause hypotension, and they can cause barotrauma, and we'll talk about that in a second when we talk about contraindications. Most of the negative studies on recruitment maneuvers have either used too high a pressures, in my opinion, or not increased the PEEP after the recruitment maneuver to keep the alveoli open that you've opened with the recruitment maneuver. So this is really a key feature. So what do I use? And basically, I base this on an animal study, which is in the reference at the bottom, which compared the three different kinds of recruitment maneuvers in three different animal models of ARDS at the same pressures. And basically what it showed was that pressure control was the best tolerated from a hemodynamic point of view, and also the most successful in terms of maintaining oxygenation at the end of the maneuver. So if you can't get your patient's O2 sat over 90 on 60% or more FiO2, and you've used adequate PEEP, then this is the time when you want to try a recruitment maneuver. So you place the patient on pressure control, an inspiratory pressure of 45, adjust the inspiratory time to get an I/E ratio of 1 to 2, and you do it for 2 minutes. You have to watch carefully for hypotension and evidence of barotrauma. Generally speaking, non-pulmonary ARDS, meaning ARDS caused by pancreatitis, for example, will respond better than pulmonary ARDS caused by pneumonia, for example. But it's highly unpredictable, and really it's one of these things you just have to try, and fortunately you'll find out within 2 minutes whether your patient's going to respond or not. Usually the O2 sat improves dramatically if they're a responder, and it doesn't improve at all, or maybe even goes down in a non-responder, in which case they were a non-responder, no point in using further recruitment maneuvers. If the O2 sat does improve with a maneuver, you've opened up alveoli, but you want to keep them open. So you set the PEEP 2 centimeters higher than whatever it was before, and you watch a patient. Sometimes it'll last for a few minutes, 15 minutes, 20 minutes, and then the O2 sat goes down, and you have to repeat the recruitment maneuver, and again, increase the PEEP 2 more, and you have to find the spot where the recruitment maneuver sustains oxygenation. Again, you are limited by your plateau pressure. You don't want that more than 30. Sometimes we'll go even as high as 35, especially in a very large person, but you are limited by that. What are the contraindications? Well, we don't want to use this in unilateral lung disease because it just overinflates the good lung. We don't want to use it in patients who are very hypotensive despite fluids and pressors. We don't want to use it in patients with evidence of barotrauma, pneumothorax, pneumomediastinum, pneumatoceles, bullous lung disease, bronchopleural fistulas. And we don't want to use it in patients with an elevated intracranial pressure because it will further increase the intracranial pressure, though it depends on how high the ICP is. So where do recruitment maneuvers fit in our armamentarium of treatment of ARDS? Well, this is from a chest article, and we sort of follow this as well, and there's ventilatory maneuvers and non-ventilatory maneuvers. So for the ventilatory maneuvers, we try increasing the PEEP, then we try lung recruitment to see if the patient is recruitable. Whoops. And you can try super PEEP. And then for non-ventilatory maneuvers, we try We use inhaled vasodilators. We use prostacyclin because nitric oxide can cause renal failure. Then we try neuromuscular blockade, and then we try prone positioning. And if all of the above does not work, you consider ECMO. So in summary, recruitment maneuvers can be very helpful. It's unpredictable who's going to respond to them, but it's worth a try if there are no contraindications.